My name is Nate Cuevas. I'm a registered nurse. I've worked med-surg, tele, IMU, corrections, psych, forensic psych.
Football field. What's the use of a helmet? Shouldn't helmet supposed to be taking care of those kind of brain damages?
Well, you even though your head's in the helmet, your brain in the skull will move around.
If you are into content that inspires, surprises, and sticks with you, hit that subscribe. Turn on those notifications, and let's get busy. As a medical profession, I quickly observed that working with patients who have both psychiatric conditions and traumatic brain injuries can be both challenging and fulfilling. Success in this field requires heart, compassion, and empathy. In practice, medical staff may encounter patients experiencing aggression, mood swings, cognitive disabilities, PTSD, psychosis, schizophrenia, antisocial behaviors, short-term memory issues, severe depression, and other difficulties. If the staff is not cautious, the safety of themselves and other patients could be compromised by some of the more unstable patients. Today, I'm pleased to have a dear friend and a former colleague with extensive experience in this field who will be sharing his knowledge to the viewers. But before we proceed, please consider liking, sharing, and subscribing to our channel as we have more engaging content planned. With all respect, please introduce yourself and a little bit about your work experiences.
My name is Nate Cuevas. I'm a registered nurse. I've been a registered nurse since 2012. Graduated from UT Houston in 2012, Bachelor's of Science. Also have an Associate's of Science. I am a bachelor degree nurse. My experiences, I've worked med-surg, tele, IMU, corrections, psych, forensic psych, what else? I was a CNA before I became a nurse. I've worked in all the med-surg units at one of the local hospitals here in Conroe, mainly med-surg, ER, ortho, did a little bit of peds. Currently, I am working neuropsych at a post-traumatic brain injury rehab facility. Also take atraumatic brain injury and also spinal cord injury. So a lot of neurological.
Both of us pretty much look like we've done almost the same things. Yeah. Because I've done med-surg. Yeah. I've been a med-surg nurse, psychiatric nurse. I've been all over the place, but I don't think I've done as many as you. Yeah, but I've been in the field since 2015. Yeah. So anyway, our discussion today will center on traumatic brain injuries, mental health, and hormones.
Yeah.
So right now you're into
neuropsych.
You're neuropsych.
Yep.
So how's neuropsych different from
other psych facilities?
No. Yeah, psych facilities.
So basically, neuropsych is where I'm at is a post-acute rehab facility. It's not an acute care facility like an acute care psych facility. Yeah. So we just don't get any acute psychotic off the street, brought in on an EDO from any of the county. But we have admitted their residents. They live there. They're there long term. We have had admitted former prisoners that came straight out of prison and lived there. But they've had the admission criteria is they've had to have either an atraumatic or a traumatic brain injury, along with some kind of mental health disorder like schizophrenia, bipolar. Or maybe a history of substance or alcohol abuse. Anything that's affecting mental health.
So when most people think about traumatic brain injuries, there's understanding. is always shaped by what they see in the news, movies, or from sports like boxing. What's your thought?
Yeah, so according to the CDC, the most common cause are motor vehicle accidents and falls.
False.
And then you have your sports injuries, football, boxing. Concussion is even considered a form of a traumatic brain injury.
Or concussion.
Yeah, and so you got to think about the the normal functioning of the brain, and then when it becomes damaged, the different parts of the brain, whatever's damaged, is how that individual is going to manifest, whether it's their behavior or their physical. Some brain injury patients that I take care of do have physical disabilities also, like they might have left-sided hemiplegia or right-sided hemiplegia, spasticity. Some are in wheelchairs, and then cognitively, some of them could be forgetful, easily agitated, aggressive, very impulsive. Patients that I take care of, and we have neuropsychiatrists and psychiatric nurse practitioners. They are the providers for this population, and it can be a difficult population to work with.
So when these guys are injured, you know how they're injured, right? They have these causes. Yeah. Is the treatment reversible or irreversible? Once you have it, it's permanently brain damage.
So once the brain is damaged, it's not like liver or skin. It doesn't regenerate,
So that's permanent.
Damage is permanent.
It's permanent.
Yeah.
Oh,
so,
okay.
I mean, you have your acute stages after whatever the injury cause was, whether it's a penetrating or a bump, bolt, or jolt. Whatever the cause is, you have your initial acute phases. You could lose consciousness, and be in a coma, the most severe type. Yeah. Or you could have just lost consciousness for like 5-10 minutes, like in a concussion. Football hit helmet to helmet, or boxing. Knocked out.
I still don't understand how people get TBI in football field. What's the use of a helmet? Shouldn't helmet supposed to be taking care of those kind of brain damages?
Well, you even though your head's in the helmet, your brain in the skull will move around.
Okay.
Once you hit, so just like when even in a car accident, a motor vehicle accident, whiplash, and your brain moves, shakes around, and so you might have different metabolic processes and chemicals that can cause injury.
So, what are the most challenges mental health professionals face, especially in the field that you're working at? Day-to-day practice.
I would say, from my experiences, sometimes it's a lack of education, a lack of training that can make the I would say the unit more volatile and dangerous. Some people, some support staff don't have the kind of education or background that us nurses have. So they're not as educated on the pathophysiology and why these patients are behaving or the way they are, versus somebody who's got more knowledge and education and understands why they're behaving like that. Some of the staff I've worked with in many different past facilities have talked to psych patients like they're from the streets and they're ready to brawl. You can't do that with psych patients.
Oh, okay.
You know what I mean? Yeah. I know it. We've been in situations, we've been in crisis situations, and you kind of want to say some things, but you got to step back and think. You're like, we're professional,
professionalism,
and we can't be doing this like we're from the streets or
yes.
So and staff that I've worked with in many different places in the past have done that and gotten themselves in trouble or fired. Or even lost certifications or licenses.
Yeah, I get it. But how do you build rapport with patients that are resistant to treatment?
So, build a nurse-patient relationship. So, I mean, if they're cognitively appropriate and they can understand, you know, and they can talk and they're with it, just, you know, you introduce yourself and you kind of, you know, learn about their past history, their medical history. I would say the more you know about them, the easier it is to establish that patient, you know, nurse-patient relationship.
So those are like long-term. They're long-term.
They're
long-term.
Yeah, they're long-term residents there. They're not there like 2 or 3 weeks, like an acute psych facility.
So how long would a patient be? Years or months?
Some of them live there. Some of them could be admitted for 30 days, and then some 3, 4 to 6 months to years.
I assume you've been into some intense physical holds on aggressive patients. Could you tell us some of the outcomes of such situations?
Yeah, so the facility I'm at now, we utilize SAMA. So
a lot of people don't know SAMA. When you say SAMA, what is SAMA?
Satori, aggression for management. I can't remember all of it.
Oh, okay.
But it's SAMA it's kind of like how you would CPI, a little bit less hands-on, more verbal de-escalation first.
Oh, okay, yeah.
And then, you know, last resort is you never want to really put your hands on patients unless, you know, they're a danger to themselves or others. Then, you know, you have to utilize the whatever policies in place.
Oh, okay. So you're working 12 hours, right? It's a 12-hour shift?
12 hours.
Or 12-hour shift. Okay, so how do you measure treatment success in the health settings?
I would say with the population I work with, you see how when they're admitted, you see how they are. It's not just when I say neuropsych and brain injury, they also get rehab. They have rehab services at the facility too, where they get PT, OT, speech, cognitive therapy, behavioral therapy, psychotherapy. Some of them that have you know, physical difficulties. They'll get, you know, physical therapy if they have trouble talking, then speech therapy. If they have behavioral issues, occupational therapy to help with like any ADLs, IADLs. And then, you know, we have, like I said, we have a neuropsychiatrist, psychiatry, psychiatric nurse practitioner. And we got the medical side too to look after the medical aspects if they have any medical issues.
Okay. So what was the most difficult situation you ever been to?
You talking about in my whole psych nursing career or?
I would say both. Because I know psych and TBI pretty much goes together some way,
I would say the difficult, I think it was mainly the past facility we worked at together. We had some big guys that would always try to, you know,
more
try to get more aggressive, but that's just because of their size.
Oh, okay.
And they knew what they were doing.
Oh, okay.
I think you probably know what I'm talking about.
Yeah.
Where I'm at currently, I think the ones that are more confused that you can try to verbally de-escalate them, but they have no comprehension. Those are, I would say, those are the most challenging because they don't know what they're doing. Can be very impulsive.
Oh, okay.
And it can be very tough.
Could be tough.
Yeah.
Man, that's a tough job. Okay, so on cultural issues, right? How do cultural differences affect mental health treatments and outcomes?
It's kind of difficult to answer because I would say majority of our population, it's a mixed population.
It's a mixed population.
We got Hispanic, Black.
Is approach different? Let's say, you know how you approach a Black patient or a Caucasian patient, Hispanic patient, or maybe African?
Your approach is different with everybody with this type of population because if somebody is alert and oriented, that maybe not be psychotic or whatever, that's on their meds, you would approach them differently than somebody who's confused and impulsive.
Oh, okay.
And then sometimes we have all kinds of different.
Oh, okay. So how do clinicians differentiate between psychiatric disorders and TBI symptoms? I still don't understand that. The doctors, right? How do they differentiate a patient with a psychiatric issue from a patient with TBI or maybe dementia?
So a TBI patient could still be psychotic. They can be confused.
Is the treatment the same or
treatment is
medication?
Treatment approach medications is pretty much the same. We use antipsychotics, mood stabilizers, antidepressants.
Oh, okay.
Benzodiazepines for anxiety, antihistamines for anxiety.
Oh, okay.
I would say a lot of with the TBI population with mental health disorders, a lot of them do have other neurological issues like seizures.
Oh, seizures.
So there's a lot of valproics in benzos.
Oh, it's kind of the same. Kind of similar. It goes together. Okay. So what role do family education and involvement play in TBI recovery?
What's that?
With family, let's say family involvement. Because I know sometimes you also have to involve the family, and you have to educate the family.
Yeah.
Upon patient's discharge.
So
do you do that family teaching?
Family teaching.
Yeah, do that. Prior to discharge. Okay. What are the most common long-term effects of traumatic brain injuries on cognitive and emotional functioning?
So long-term cognitive deficits, it could be a lot. Like short-term memory deficits, forgetting where you're at. May have not even know where you're at or what your name is. Repetitive questioning.
Yeah.
Ask the same question over and over and over. Perseverating on the same subject. And I'm very, very forgetful.
Man, that might be tough.
You have your days where you just want to get out of there, but I mean, you have to have a lot of patience working, just in being a nurse in general. But with the psych population, or just with this population, you have to have a lot of patience.
So, what's the patient staff ratio?
So usually 16 beds, 3 CNAs on the floor, a nurse and a medication aide.
One charge nurse, med nurse.
So you have your so it's like your nurse, and then you have a med aide. We don't have a medication nurse.
So basically, you as a nurse, you
do assessments
and also giving meds. Same time.
Meds, PRN and emergency meds, and medication. They is able to administer medications under the supervision of a licensed nurse.
So you're pretty much doing everything.
Yeah,
just one nurse or 2 nurses?
One nurse. But with the help of a medication aid, it's like having a second nurse, but they can't.
Yeah. I get it. I get it.
They can't do assessments though.
Oh, yes, I get it. Yeah.
Give certain medications, injections.
Yeah, I get it. So, what rehabilitation strategies are proven most effective for patients with moderate to severe TBIs?
What was it? Say it again.
Like rehabilitation strategies that have proven to be effective when you're dealing with patients with moderate to severe TBIs.
Well, a lot of psychopharmacology, therapy.
Oh, therapy. Okay.
Physical rehab, cognitive, and seems like certain medications work better after a brain injury. Seroquel,
okay.
NAC.
Okay. These are psych meds, right?
Seroquel is psych med. NAC is N-acetylcysteine. It's a supplement.
Oh, never heard of that. Okay.
Usually given it for Tylenol overdose, but it can be used for impulsivity in this population.
Oh, I can calm them down. Okay. I've heard some doctors use testosterone and estrogen hormones on neuropsychiatric treatments. Right? How effective are these drugs?
Well, if your hypogonadal axis isn't working, you're not producing adequate hypogonadal axis for hormonal like testosterone production. If that part of the brain is injured, you're not going to be producing that anymore. So you might have low testosterone because you make you more irritable, agitated. But then again, it's a double-edged sword because if you start the patient on TRT therapy, testosterone levels are too high, maybe estrogen levels go up with it, can cause aggression and irritability. But I will say that with some of the population I work with, they did start some of the patients on TRT therapy just to increase their muscle strength. Because like with TBI, you could, if it's like stroke, you can have a left-sided or right-sided deficit in muscles. So, okay. Well, like I said, if your testosterone's low, you're probably not feeling good. You probably don't have a lot of energy. If your testosterone's within range, everybody's different. One person could feel better than the next person, depending on the range of the testosterone levels. Oh, okay. But like I said, it's not for everybody. It's an androgen, and it can, like I say, it can lead to irritability if it's not well managed. Okay. So as a nurse, have you ever have some days where you feel like some of the physicians or administrations are not being supportive? I would say, because most parties is an RN that sits there with the patients like 12-hour shifts. No, I don't think so. Not where I'm currently at, but I would say in the past other facilities I've worked at, yes. You have a good team. Yes, we have a good team. Okay. And like I said, if you have the skills and the knowledge, because there's different units, and not all units have neuropsych. Oh, neuropsych. Okay. So, if with my background, they put me on the unit because of my skills and my knowledge and how well the unit is managed. Oh. So how often do doctors see them, patients? It just depends. They have treatment team meetings, which you have to attend to, right? Yeah. Oh, okay. So I'd say it's twice a week. Oh, like twice a week? And then sometimes they round on the unit. Oh, okay. So overall, do you feel like the treatment management is effective? Yeah, I do think from what I've seen, the treatment team collaborates, and of course, when you're in the treatment team meeting, members of the treatment team do report on specific behaviors and outcomes of the current treatment. Okay. And if things need to be changed or adjusted, then that's usually when it's made. Or even when you're working on the unit and you see something that's not working or you haven't seen, then you be proactive and notify the provider, say, hey, I see some changes, changes in status, and what can we do? Oh, okay. Well, Big Ned, I think that's all I have today. That's all good, man. That's all good. I appreciate being here. But I feel like we're still going to do more. Oh, yeah. Thank you, man. Yeah. I appreciate you. Thanks for coming. Yeah.